Upper GI endoscopic findings in scleroderma. This presentation features a case of scleroderma with characteristic upper GI involvement. The endoscopic findings, pathophysiology, diagnostic evaluation, and management strategies are discussed briefly. A 57-year-old Caucasian female with past medical history of scleroderma presented to our gastroenterology clinic for further evaluation of a 2-week history of dysphagia for solids and liquids. She also had a chronic gastroesophageal reflux disease that responded partially to proton pump inhibitors and recurrent episodes of aspiration pneumonia. As part of our diagnostic workup, a barium swallow was done that showed diminished esophageal peristalsis and a patulous gastroesophageal junction. A liquid gastric emptying study was abnormally prolonged. An esophageal manometry study was done which revealed a very low resting lower esophageal sphincter pressure of 4 mm mercury and slow or absent peristaltic contractions with low amplitude waveforms. Her manometry tracings are shown here. You can see the low amplitude waveforms and the absent peristaltic contractions as the swallowing sequence progresses. Let's look at her upper GI endoscopy video. You can see the remarkably low or absent esophageal peristaltic movements, diminished muscle tone in the lower esophagus, and a wide open lower esophageal sphincter. Retroflexed views from the stomach again show the wide open lower esophageal sphincter and the lower part of the esophagus. The scope is now being withdrawn and the patulous gastroesophageal region is again noted. The major pathophysiologic mechanism in scleroderma is an innervation defect of the gastrointestinal tract, secondary to inflammatory changes in the vasa nervosum or due to the deposition of collagen that causes compression of the nerve fibers. The resultant ischemic injury is the main reason for denervation of the gut. Eventually, smooth muscle atrophy and muscle fibrosis occur along the GI tract, and these changes are essentially irreversible. As a result of the neural defect, muscle atrophy and fibrosis, the lower esophageal sphincter becomes incompetent and esophageal peristalsis is significantly impaired. All of these collectively lead to severe gastroesophageal reflux. The upper gastrointestinal involvement in scleroderma can be broadly divided into esophageal, extraesophageal, and gastric pathology. Esophageal pathology. Esophageal involvement is a very common finding in scleroderma, with up to 90% of the patients having symptoms. Dyspepsia and dysphagia are very frequently reported. Infectious and pill-induced esophagitis, bleeding, ulceration, and stricture formation, Barrett's metaplasia, dysplasia, and cancer can occur secondary to impaired peristalsis and chronic acid reflux. Extraesophageal pathology. Oral ulceration, chronic cough, hoarseness, pharyngitis, asthma, and recurrent aspiration pneumonia are a result of acid reflux higher up into the pharynx and from motility dysfunction. Gastric pathology. Delayed gastric emptying or gastroparesis leading to early satiety, bloating, nausea, and vomiting, and gastric antral vascular ectasia or GAVE are the main findings in the stomach in patients with scleroderma. Diagnostic evaluation. Upper GI evaluation of patients is done with the aid of barium studies, liquid and solid gastric emptying studies, esophageal manometry, a 24-hour ambulatory pH monitoring, and an upper GI endoscopy. Medical management of symptoms from gastroesophageal reflux is done by reflux and aspiration precautions, antacids, histamine antagonists, and proton pump inhibitors. Smaller meals, prokinetic agents, and octreotide can all aid the GI motility in these patients. Early medical therapy and behavior modification are crucial for preventing complications and for reducing morbidity in these patients. Surgery has a limited role in the management of scleroderma upper GI involvement and can be considered for patients with refractory symptoms.